Everyone for inviting me to come in and talk to you. That's an impressive marathon that you guys have just run. You are certainly feel free to fall asleep during this presentation if you like. I won't take it amiss. But Dr. B asked me to talk to you guys about minimally invasive parathyroidectomy. So you should feel free to stop me at any point, ask any questions along the way, or we can chat at the end. I have nothing to disclose. So just by way of overview, I thought we would talk about what really defines a minimally invasive parathyroidectomy. We'll talk about the pros and cons of focused versus bilateral neck explorations. We'll talk a little bit more detail about parathyroid imaging, which is something that you guys may be very interested in. And then I'll show you just very briefly some stuff about the technique of minimally invasive parathyroidectomies. So what exactly is a minimally invasive parathyroidectomy? No one actually really knows. So there's really no consensus. So when you talk to different surgeons, they'll tell you different things. The Italians will tell you a minimally invasive means that it's a video guided. That guy down in Florida will tell you that it's using MEBI guided type of surgery. Some people will tell you only local anesthesia qualifies. Some people will tell you that it could be either a focused parathyroidectomy or a bilateral neck exploration. So there's really, again, no consensus. Perhaps what everyone can agree on is that it's done through a small incision, right? And so, what defines a small incision? Who knows? So typically, we do our parathyroidectomies through a 2.5 centimeter incision. Most people would consider something over, 4 or 5 centimeters to be a big incision. And so when I said, when I said that no one really knows what a minimally invasive parathyroidectomy is, I was sort of being disingenuous. So the American Association of Endocrine Surgeons is about to publish their parathyroidectomy guidelines, and that'll come out in JAMA Surgery, I think, in the next couple of months. And so the definition for our group was doing a focused exploration. So that's what a minimally invasive parathyroidectomy means in the AAS parathyroidectomy guidelines. So anything else other than going after a single disease parathyroid gland qualifies as does not qualify as minimally invasive. And so again, lots of people will quibble with that definition because many people will say that they can do a bilateral neck exploration through a small incision and again, in a minimally invasive approach. So when we think about how we do parathyroid surgery, the main question or the main philosophical divide is, are you a surgeon that does focused explorations or are you a surgeon that does bilateral neck explorations? And so when you do a focused exploration, that typically means that you're doing an image-guided operation. So you do preoperative localization, and the intent is typically to remove a single disease parathyroid gland. Whether they have, and 80% of patients roughly have, a single disease parathyroid gland, 10% have 2 or 3 parathyroids, and another 10% will have 4 gland hyperplasia. There's a lot of interesting stuff coming out now saying that double and triple adenomas actually doesn't exist, and that if you follow those patients for long enough, that patients with 2 or 3 adenomas will actually end up having 4 gland hyperplasia. So the group at Pittsburgh and in Wisconsin followed patients for 10 years, and what they found was that in most good series, the recurrence rate at a year is about 1%, 1 or 2%. And so what they found is that if you follow these patients for 10 years, that the recurrence rate was probably closer to 5 to 10%. And most of those late recurrences were patients who had double or triple adenomas because in reality they had 4 gland disease. So in any case, and typically with a focused exploration, you're using intraoperative PTH to confirm that you've removed enough parathyroid tissue, and we'll talk about that in a second. When you're doing a bilateral neck exploration, the intent is that you're going to visualize all 4 parathyroid glands and remove any abnormal parathyroid glands that you see. And whether or not you use preoperative imaging, whether or not you use intraoperative PTH doesn't matter so much. That's really up to the individual surgeon. So when I think about the decision-making behind doing focused versus bilateral neck exploration, I always think about my friend Herb Chen. Herb used to be the chair at, the head of endocrine surgery at University of Wisconsin. He's now the chair of surgery at UAB. And so, Herb always thought about it like this, that you break it down into these 5 factors, and cure rate, complications, operative time, incision length, and length of stay. So going from, top up, we're going to try and figure out if there's a dominant strategy. So when you think about focused versus bilateral neck explorations, most surgeons who do high volumes can do this as an outpatient procedure. So inpatient parathyroidectomy, typically we typically don't do that anymore, mainly because the operation is so safe, the complication rate is so low that it's perfectly safe to send these patients home. At Columbia, we wait 4 hours just to observe them for potential neck hematomas, which can be life-threatening. But after that, we send them home. And the 99.5% of patients who are going to have a bleeding problem will have it within that first 4 hours. If you have a late bleeding problem, it's usually in someone who has a bleeding diathesis, hemophilia, that kind of thing, or someone who's on anticoagulants. Some groups will actually just observe people for like 20 or 30 minutes and send them home, but that seems a little cavalier to me. So when you're thinking about focused versus bilateral neck exploration and how long you keep them, it doesn't really matter. We send patients home who've had total thyroidectomies for big goiters, that kind of thing. So outpatient neck surgery, absolutely a possibility for pretty much any neck disease. And so this is sort of a wash, both focused and bilateral, you can do outpatient surgery. Again, we talked about incision length. Most people will say that if you're going to do a bilateral neck exploration, the incision has to be a little bit bigger, but not much, but just a little bit bigger. And again, our standard incision is about 1.5 to 3 centimeters, depending on the patient's habitus and that kind of thing. So this is, roughly equivalent. Operative time, it's very clear that focused explorations usually take a much shorter period of time because you're really just going after one diseased parathyroid gland. Having said that, bilateral neck explorations doesn't take that much longer. About 45 minutes is about the average time. At Columbia, that's in the literature. At Columbia, the average time is probably closer to 20 to 30 minutes. And for focused, it's usually closer to 10 to 15 minutes. So the caveat to that is one of the assumptions behind doing focused exploration is that you're going to do intraoperative PTH. And so when we do intraoperative PTH monitoring, usually it takes about 15 to 20 minutes for us to get those results back. So the operative time is roughly about the same, the amount of time that they're in the operating room. So this ends up being pretty much a wash as well. And so when you're thinking about complications, right, the complication rate, as you guys know, hopefully the complication rate is very, very low. And the main complications we think about, bleeding and infection, those are certainly less than 1% in almost every series that you see. Recurrent laryngeal nerve injury leading to some hoarseness, and hypocalcemia, hypoparathyroidism. So when you look at large series and some prospective randomized trials that have looked at focused versus bilateral neck exploration, the complication rate for recurrent nerve injury is essentially identical. No major difference, mainly because the rate is so low. But when you look at the rate of temporary hypoparathyroidism, it's pretty clear that there's a higher rate in patients who've had bilateral neck explorations. This isn't just like the mild laboratory abnormalities. This is patients who end up having symptomatic hypocalcemia. But again, the vast majority of these cases are temporary hypocalcemia. One of the putative mechanisms of this is that when you're doing bilateral neck explorations, you tend to identify more diseased parathyroid glands than if you're doing a focused exploration. So they have a bigger resection, And then again, sometimes when you're looking at parathyroid glands and dissecting them out, sometimes you compromise the blood supply temporarily, and the parathyroid glands get a little unhappy. So in this regard, the focused exploration has a little bit of an edge over bilateral neck exploration. And then when you look at cure rate, this is ultimately what we really care about. If you look at the large series that are out there, the cure rate is essentially identical between unilateral and bilateral neck explorations. Again, interestingly, when you look at the 10-year, and this is all at 6 months to a year, but interestingly, when you look at the 10-year follow-up rate, the patients who've had bilateral neck explorations, it wasn't statistically significant, but there was a trend towards having a lower recurrence rate if you had a bilateral neck exploration versus focused. So again, this tends to be a wash, and really what we say is the choice of technique depends on the individual surgeon's preference, but also the individual institution, because some places don't have intraoperative PTH, some places have better localization than others. So at Columbia, we tend to favor an image-based focused exploration with intraoperative PTH. We typically don't do frozen sections. If you've seen enough parathyroid glands, 95% of the time you can identify it visually. 5% of the time it's hard to distinguish between a lymph node and parathyroids, but that's pretty uncommon. and we do send them home the same day. One of the reasons we tend to do a focused, image-based focused exploration is because we have great imaging here, and I'll show you that in a second. So as you know, Dr. Bill Zekian was saying, you know, like this is John Dotman. He is one of the great endocrinologists / nuclear medicine people at the NIH, and this is his famous quote, as you guys have heard. And so, looking at the anatomy of the parathyroid glands, you're all familiar with the classic anatomy, right? Typically around the tubercle of the thyroid, but there's lots of variation in where these parathyroid glands can be. So lots of ectopic locations. So upper glands can be way up high by the salivary glands. They can be way down in the chest, but the most common location is in the tracheoesophageal groove. Much more variability with the lower parathyroid glands, again, high up in the neck. In the anterior mediastinum is another classic location for it, but the most common ectopic location for lower glands is in the thyrothymic ligament, that little piece of thymus that comes up and joins up with the thyroid. Interestingly, both parathyroid glands, upper and lower, can actually be intrathyroidal glands, and both of them can actually be in the carotid sheath. So lots of variation in terms of where parathyroid glands can be, and about 20 to 25% of patients will have ectopically located parathyroid glands. And so for that reason, imaging can be very important, because no amount of looking around in the neck, I don't care how good of a surgeon you are, you will never find this mediastinal parathyroid through a neck incision. And so for me, the goal of localizing studies is to limit the amount of pain for both the patient and the surgeon, right? You know, I have been in that situation where I did not get localization on a patient pre-op, and I was looking for 3 or 4 hours in all the usual locations and couldn't find it because it was down in the chest. So for that reason, I think you know, imaging is a very nice thing to have. So when we think about what makes the ideal test, obviously you want to localize the culprit gland, and there are lots of ways to do this, whether you use anatomic size as the definition or functionality is a question. It should provide you a roadmap of where to look, so it should give you a good idea as to the surrounding structures and where exactly this thing is hiding. In the ideal scenario, it will tell you what where the normal parathyroid glands are, and this is very important for patients who have the so-called mild biochemical parathyroid disease, the normal calcemic disease, the inappropriately normal parathyroid hormone. You know, we just published our study, our experience here, and what we found was that patients who have normal calcemic disease have a much higher rate of foregland hyperplasia than patients with classic parathyroid disease and even normal hormonal disease. And then the patients who have normal hormonal disease, they have much smaller diseased parathyroid glands than patients with classic disease. So that's just a long way of saying those mild biochemical profiles tend to have less abnormal parathyroid glands. And for that reason, imaging can be very, very important. It should also tell you if there's associated thyroid disease, so that way you can assess it preoperatively and deal with it intraoperatively if necessary. It should minimize radiation as you can get it to do so. And so when you're thinking about the classic test, and you have to interpret the results appropriately. And so defining what is success, you know, is this a true positive? You know, whether this localizes to the exact gland that's diseased, the quadrant of the neck, or even the side of the neck. When you look at the radiology literature, the definition of successful localization differs, you know, pretty widely, so it's important to take a look at that. The positive predictive value in these cases, obviously the likelihood that an identified adenoma will actually be there and be the diseased gland. And when you're looking at imaging, especially again those mild biochemical profiles, true negative can be as important as a true positive. So again, telling you that a gland is actually normal is incredibly important. And one of the overriding themes is that specialist review, endocrinologist, surgeon, radiologist with a specialty is much more accurate than just a general radiologist. And so, you know, lots of literature bears this out, that, you know, high volume radiologists with parathyroid specific experience have a much higher rate, much higher accuracy than not. And so it's critical that you always look at the imaging yourself. The other overriding theme is that you should never use the results of imaging to make a diagnosis or to determine if you're going to do an operation for a patient, right? And so that's like one of the classic dictums of parathyroid disease, is that imaging doesn't tell you when and if you should operate. So of course, the corollary to that dictum is that sometimes you use it to help you figure out if you're going to send a patient for an operation, right? So if someone has had a gastric bypass previously and they have normal calcemic disease and you're not quite sure if you should send this patient for an operation even though you're convinced it's normal calcemia, not vitamin D deficiency, sometimes you'll get an imaging test, and if there's a big Goomba sitting there, you would send them for an operation, and if there's not, then you might really try and pump up their vitamin D, that kind of thing. So, you know, there's a caveat to every rule, and that's definitely true here. So we're going to talk very briefly about some of the imaging tests. Just a word about MRI. It's terrible for parathyroid disease, so there's almost no indication for doing an MRI for parathyroid disease. There's a high false positive rate for thyroid nodules and lymph nodes. Some of the benefits, you know, we typically, if you're going to get an MRI, we typically reserve it for reoperative cases where you want to get confirmation of a mediastinal adenoma, but again, not so great for that. But it's expensive, poorly tolerated, poor sensitivity. Patients just absolutely hate it. So MRI we tend not to get. And this is a table from Kunzman's JCEM paper kind of summarizing the pros and cons of all these imaging tests. Ultrasound is a classic. And so the classic finding is that you see this hypoechoic structure, usually posterior to the thyroid, and classically it's a teardrop-shaped structure. Ultrasound can be very valuable. So in most studies, the sensitivity is about 70 to 80%. In certain specialty studies like parathyroid, dedicated sonographers can have up to a 95% accuracy at finding diseased parathyroid glands. But there are lots of potential false positives. Thyroid nodules, lymph nodes can also look hypoechoic, be in that same central neck compartment. But there are lots and lots of benefits. It's fast, it's office-based, you can bill for it. There's no radiation involved, and you can actually do intraoperative, fine needle sampling of these parathyroid glands. When you do a biopsy of a parathyroid gland, almost always the cytology is going to look like follicular cells. So they will never tell you it's a parathyroid biopsy, but they'll tell you it looks like follicular lesion. And so it's imperative that you do PTH washouts for these. So basically you do the biopsy just as you would a thyroid nodule biopsy, but then you wash out the needle with a little bit of saline into a blood tube and send it for PTH levels, and the PTH levels usually are in the thousands when you're in a parathyroid gland. One of the main benefits is that it can help you delineate intrathyroidal parathyroid glands, unlike most of the other imaging tests. And again, it's the best test for looking at thyroid lesions. You know, lots of limitations. It's definitely operator dependent. There's definitely a learning curve to learning to do this well. It doesn't penetrate bone or air very well. And so the classic place that ultrasounds will miss parathyroid glands are the TE groove upper parathyroid glands, because oftentimes the trachea and the esophagus can kind of overlie it and block adequate transmission. You can't see mediastinal glands with these guys, and it will typically miss small parathyroid glands. And so lots and lots of studies showing, again, that specialist performed ultrasounds have a higher diagnostic rate. And they give you a more useful description, a more useful roadmap as to where the lesions are, and have increased accuracy. So ultrasound is a great modality, great positive predictive value. It's cheap, and there's no radiation exposure to it. So from a Sestamibi standpoint, as you all know, the basis of Sestamibi is that Mibi is taken up by cells that have lots of mitochondria, and the way they discovered this was initially, they used to call Sestamibi a technetium cardiolite because they would use it for cardiac perfusion scans. And some smart cardiologists noticed that patients with high calcium levels happen to have uptake in the neck, and that's how they figured this all out. It concentrates in parathyroid adenomas, some thyroid nodules like follicular adenomas, the salivary glands, and the heart. And so what you're really kind of depending on is that it takes a longer time for the radiotracer to wash out of abnormal parathyroid glands than it does to wash out of these other structures. Primarily, they think because it has a higher ratio of oxophilic cells. Lots of different ways to do Sestamibi scan, and how you do it really depends on your individual institution. And we'll talk a little bit about these here. So this is what the classic scan looks like. You can see that when you see this line here, that's typically the injection site of the radiotracer. These are the salivary glands, and when you look at the salivary glands, it's very important to look at the salivary glands individually because occasionally, less than 1% of the time, you can actually have an undescended parathyroid gland that's up by the salivary glands, or at least in that region. And so if you see distinct asymmetry between the uptake in the salivary glands, it should raise the suspicion that maybe you have an undescended parathyroid. And then, of course, the heart lights up pretty brightly here. And this is where all the action is at. So again, with the delayed technique, what you're really depending on is the delayed washout of the radiotracer from the parathyroid. So typically you scan them right after the injection, and you'll get a picture of what the thyroid and the parathyroid look like, and then you wait 2, 3, 4 hours, depending on the protocol, and you're waiting to see the tracer wash out of the thyroid. And so hopefully you're left with a nice light bulb, as you can see here. One of the most accurate forms of Sestamibi scanning is the so-called dual isotope subtraction technique. So not only do you give them technetium, but you also give them radioactive iodine, so I-123 typically. The I-123 should only go to the thyroid, the technetium should go to both, and then you subtract out those two images. And then again, you're left with the ghost of what the thyroid looked like, and then hopefully you're left with just a clear parathyroid adenoma there. SPECT CT is sort of the new kid on the block for Sestamibi scan. And one of the benefits is that it can give you great anatomic detail for the location of these diseased parathyroid glands. Regardless of what technique you use, Sestamibi scan is notoriously bad at finding multi-gland disease. In some cases, you can see multi-gland disease, but in general, it will miss up to 30 to 40% of multi-gland disease, even in the best of hands. Lots of different types of false positives. So, here's the I-123 scan for this patient who had follicular and Hürthle cell neoplasms. And so you can see that, again, certain types of thyroid lesions can give you false positives. So in general, the sensitivity of Sestamibi, depending on the institution, is about 80 to 90% for single adenomas. And at the very minimum, you have to do delayed imaging of these in these scans. Subtraction imaging tends to give you a better sensitivity rate, but it can be affected by things like thyroid hormone replacement, that kind of thing. Excuse me. And again, SPECT is particularly good for mediastinal disease, stuff high up in the neck. So the false negatives, cystic parathyroid adenomas can give you a false negative as well as multi-gland disease. And so it's a pretty good sensitivity. It can help you identify ectopically located parathyroids, especially in the mediastinum high up in the neck. And the key thing is that this is a functional test, not just an anatomic test. And so, and there's an acceptable radiation profile. But again, the accuracy in multi-gland disease is not great, and the quality is highly variable from institution to institution. So if you're sending your patients for amoeba, you want to send them to a high-volume institution, and usually misses small glands as well. Most places are moving towards SPECT CT as sort of their go-to parathyroid imaging. There's a little bit more radiation involved with that, and it's a little bit more expensive than some of the other modalities. So interestingly, there are lots of papers out there about combining ultrasound and Sestamibi to give you a better positive predictive value. And so this is the so-called Kabebu score from UCSF. And you get 1 point each for a calcium above 12, PTH 2 times above the upper limit of normal, a positive MEBI, positive ultrasound, and if the MEBI and the ultrasound agree. And so you can see that this score is very heavily weighted towards the imaging, because if you have those 3 imaging characteristics, you have about a 99% chance that it's a single disease parathyroid gland. This has been correlated by others, and Ricci and those guys found that there's a 96% chance that it's a single adenoma if you have a concordant MEBI and an ultrasound. As we were saying before, sometimes negative imaging gives you some information. So if you have a positive MEBI and a negative ultrasound, that typically means that you have a low-lying upper parathyroid gland in the tracheoesophageal groove. Again, you're not seeing it on ultrasound because the lack of transmission through the trachea. So imaging is great. Like Sestamibi is great when you have something like this. This is the so-called light bulb, Sestamibi scan. But more often than not, this is what you get, right? This looks kind of like a Rorschach, like the test the psychiatrist used to tell you if you're crazy or not. And so that's most of the times is what you're getting. And so it would be absolutely fantastic if you had a scan that gave you really precise anatomic detail. It gave you not just anatomic detail, but it gave you some functional data. And that's what we're doing at Columbia. So we have, and other places, so 4D CT is sort of the new kid on the block, and probably the best imaging modality out there. And as you can see, you can get very, very precise anatomic detail as to where these things are. So you get a great roadmap. You get these beautiful images. And 4D CT is predicated on having very thin cuts through the neck and the chest. The fourth dimension is time, so it's the washout of contrast over time. And what you'll find is that adenomas have early uptake of contrast, and it washes out pretty quickly. And that's in contrast to things like lymph nodes, which tend to have a slower buildup of contrast enhancement, and it continues to enhance long after the parathyroid gland is sort of washed out. So that fourth dimension actually gives you some functional data about these tumors as well as the degree of hypervascularity, et cetera. Lots of different protocols at different institutions, but pretty much everyone agrees that you should have a non-contrast phase, an arterial phase, and at least one washout phase. So you're basically getting 3 limited CT scans. And so, here you can see this really beautiful progression of on the non-enhanced, non-contrast CT, you can see this mediastinal lesion. It enhances in the arterial phase. And then here are the side views, and you can see the nice, beautiful location here and here, that nice enhancement. And then typically your radiologist will give you this very nice description as to exactly where you can find these suckers. And they'll oftentimes give you the weight, and they'll tell you if it's hypervascular, that kind of thing. And then if they're really nice, they give you these beautiful 3D reconstructions. You can show these to your patients, and they say, "Oh, this is amazing," And then you can also add in the vasculature. So this is very important when you have, carotid sheath parathyroid glands, mediastinal adenomas, when you want to know the relationship to the great vessels. So you can get these really beautiful images, very accurate scans. And at our institution, our 4D CT is about 96% accurate. So if it tells you that there's a diseased parathyroid gland, there's about a 96% chance that they're right. And what we found is that these 4D CTs are actually very accurate in patients who've had negative Sestamibi scans previously. So, about 50% of our patients come with negative Sestamibi scans, and most of the times our scans will localize this. And this has been corroborated across many different institutions. The other great thing about 4D CTs is that it's the only modality, or one of the only modalities, that can actually identify normal parathyroid glands with a high degree of fidelity. And so that's, again, incredibly important in the mild biochemical profile patients. It's also very important in patients who've had prior parathyroidectomies, so you can see what glands are remaining, and you have a little bit more confidence that you're not taking out the last diseased parathyroid gland. So very high positive predictive value. Lymph nodes can give you false positives in certain cases, but we've talked about lots of the great benefits of it. The limitations, you really do need a dedicated radiologist. Until you personally have seen like 300 or 400 of these, they can be very challenging to read. But if you have a really good radiologist, they will do a fantastic job for you. And that's one of the reasons why I'm always a little bit hesitant, having patients get a 4D CT at an institution that I don't know, because I don't know, how good the radiologists are. Obviously you look at them yourself, but sometimes even, someone who's seen a lot of these can't really see it, There's a difference between seeing it on your little crappy laptop versus seeing it on the nice PACS machine in a high resolution monitor, that kind of thing. But 4D CT scans truly phenomenal at finding diseased parathyroids. We talked a little bit about parathyroid biopsies. This is a classic patient who had this lesion that looks like it might either be a TE groove parathyroid gland or an intrathyroidal parathyroid. Here on the ultrasound you can see it does look in fact like an intrathyroidal parathyroid, and so we stuck a needle in it. Again, the cytology typically looks like a follicular lesion, and you do the PTH washout. This has an excellent positive predictive value and gives you some truly functional data. And there's some groups that worry that this may actually seed or spread parathyroid cells, but as part of the parathyroidectomy guidelines, we did a very comprehensive review of the last 20 years of literature, and there have been 0 cases of parathyroid seeding from a biopsy. So even though it's a theoretical concern, it's probably not truly practical concern. And then finally, a little bit about selective venous sampling. Some people say that selective venous sampling is the best test for localizing parathyroid disease. But we tend not, and what you're really looking for is a step up or a gradient in one blood vessel and one vascular distribution, as you can see here. The sensitivity is pretty good. It's about 80%, and it does give you functional data. It's pretty good for mediastinal and cervical adenomas, and it may give you some information about multi-gland disease. So the real limitations is that it's invasive. So even though the complication rate is low, hematomas, that kind of thing, sometimes you can actually embolize things unintentionally. Sometimes you can cause hematomas and bleeding. So it is a more invasive test. There's lots of radiation associated with it because they have to snake the catheter up under fluoro guidance. And it doesn't really give you that precise anatomic detail. The best that SVS really gives you is sort of the quadrant in the neck where the diseased parathyroid gland is going. And it requires a lot of expertise. So we typically reserve selective venous sampling for patients who are reoperative patients. In reality, for our reoperative patients, I typically just use 4D CT scan because that typically will give us the right answer. In cases where that's negative, I will use selective venous sampling. So reoperative cases, of course. So when you have a patient who has potential recurrent or persistent hyperparathyroidism, it's absolutely critical to confirm the diagnosis. And if you haven't ruled out FHH, you should rule out FHH at this point, without a doubt. And in reoperative cases, the goal is to know exactly where you're going before you start the operation. You don't want to do an exploration. That's you sort of lost the game at that point. So you want to do a minimally invasive operation, and in general we try and localize with at least 2 different modalities to give us really that certainty that we're going after the right thing. And again, I typically use 4D CT scan. At Columbia, we actually fuse our 4D CT scan with Sestamibi. So they get both a fused MIBI scan with the 4D, and that gives you a really great accuracy. Patients with secondary hyperparathyroidism, as you know, these guys typically have 4-gland disease, and these operations are the easiest parathyroid operations you'll ever do because the glands tend to be about this big and very easy to find. It's really the postoperative care that's the pain, as you guys know. So 15% of these patients will have supernumerary glands, and oftentimes they're in the cervical thymus. So we oftentimes consider taking out the cervical thymus while we're doing these operations, because you have to rule out mediastinal disease as well. And so when you're operating on patients or sending patients with secondary hyperparathyroidism for an operation, the critical thing is, again, to think about what's going to happen to those poor people after the operation. These patients get profoundly hypocalcemic afterwards. So at Columbia, we actually have a multidisciplinary team who takes care of these patients, and we do it under protocol. So in the operating room, every patient gets a PICC line in case they need IV calcium afterwards. They get calcium levels Q2 hours for the first 24 hours, and then they get it every 6 hours after that. You have the hemodialysis folks on standby to do high dialysate calcium baths, and they get lots and lots of calcitriol. They get lots and lots of oral calcium supplementation. So it's important when you send these patients for an operation that you have a concerted plan for them after the operation is done. Just a quick word about MEN1. These patients uniformly have 4-gland disease, and they typically have a very virulent form of 4-gland disease. And so 4-gland exploration is mandatory. Typically, imaging can make the exploration easier, especially if they have ectopic glands or supernumerary glands, but it's not strictly necessary. There's been a lot of talk about how these patients tend to have thymic parathyroid adenomas and also thymic carcinoids. So the classic teaching, the standard textbook answer is that you send these patients for a 4-gland exploration and a cervical thymectomy. But when you look at the data from the NIH, what they found is that of the 350 patients that they looked at with MEN1, 0 of those patients had thymic carcinoids, and only a small percentage had thymic parathyroid adenomas. So even though it is still the board answer to do a cervical thymectomy, it's probably not strictly necessary. And so then, just to talk very briefly about minimally invasive parathyroidectomies, again, I like focused image-based explorations because it makes it easier for the patient and for myself. And the main pearls of doing this operation, you have to do this under magnification with increased illumination because everything is very small. Typically, the parathyroid lives in a separate layer of endocervical fascia from everything else, and when you kind of push around there, you can sort of see it floating around there. That's the so-called float sign. And typically, if you open that little layer of tissue, the parathyroid just kind of jumps right out at you. And so these can be very gratifying operations to do. And then typically, we dissect the gland towards the vascular pedicle, and that's sort of the last thing that we take. The one thing, or one of the things that we're very careful of is breaking the parathyroid gland open can actually lead to parathyroidomatosis. And parathyroidomatosis you cannot cure. Those patients just have these little micro implants of parathyroid glands all over the neck. Those patients, it's almost equivalent to having parathyroid cancer. It's very hard to eradicate disease in those cases. This is a very rare complication, but something that we worry about all the time. Lots of these parathyroid glands sit in the tracheoesophageal groove, which is where the recurrent laryngeal nerve is. And for that reason, we avoid using a lot of energy in that area to avoid injuring the nerve. The nerve is especially at risk for these low-lying upper parathyroid glands that we talked about previously. Some groups will do a uniform frozen section of these just to confirm they've taken out parathyroid tissue. Again, if you've seen enough of these, 95% of the time you don't really need to do that. I'm not going to bore you with all the details of this. I'll show you a quick video just to show you what this looks like. But we typically do a cervical block because the anesthesiologist can use much less anesthetic agents, and so patients recover a little bit faster. We make a small incision, we divide the platysma, and then make some flaps. And then we separate the strap muscles in the midline to expose the thyroid. We roll the thyroid up and out, and then we'll identify the diseased parathyroid gland and dissect it from lateral towards the vascular pedicle. And we'll confirm that we've taken out enough stuff with the intraoperative PTH, which we'll talk about in a second. So typically we put these patients in the supine position, tuck their arms. And when we make the incision, like the classic incision for thyroid and parathyroid surgery is that so-called collar incision where you make it low down in the neck. The problem with making low incisions like that are twofold. Number one is that typically you have to make a bigger incision, especially for thyroids, in order to get way up here to the upper pole. So the incision tends to be bigger. The other thing is, especially in women, one of the things that makes incisions kind of spread out and thicker than you like to see them is if there's a lot of tension on the incision. So especially for women, sometimes if they have large breasts, the breast will pull on the skin in the incision. And so sometimes you'll see these collar incisions that have this kind of very thick appearance, and that's typically what's going on. For that reason, we tend to make our incisions higher up in the neck, the trump card is we always put it in a natural skin line, so it kind of blends right in. So once the redness fades away, typically patients can't see that incision because it sort of acts like camouflage in there. When we do our cervical nerve blocks, we take this big honkin' syringe full of dilute anesthesia, and we do a nice C2, C3 cervical block. As we'll see here, I won't show you all the gory details, I'll just show you one thing. So when you're doing the cervical block, the key thing is that you want to hit the transverse process of the spine, and that tells you you're sort of in the right place. And then you back out a little bit and you aspirate. Just make sure that you're not in a blood vessel, because if you inject intravascularly, that can be a potentially lethal event. They get unrecoverable bradycardia. So the guy who invented this technique was Paul Legerfo, and he was here. He's a former president of the American Association of Endocrine Surgeons, and he used to call this the carpet bomb, because if you put enough dilute anesthesia back there, you eventually block the nerves that you want to block. So in general, even though it looks fairly precise, it's sort of a crude measure of what we do. And then we give a very generous field block. I'm going to skip this video and go straight to the meat of the operation. So here you can see that we are putting our clamps on the thyroid. We're rolling the thyroid up and out of the neck, and we're just kind of dissecting down into this area to identify the tracheoesophageal groove and the tubercle of the thyroid, which is roughly where we're going to find our parathyroid glands. This vessel that we're dissecting out now is the middle thyroid vein, and that's usually your first landmark that you're getting down to the right area of the neck for the parathyroid glands. Sometimes we divide this, sometimes we don't. It just kind of depends on what the anatomy looks like. Dividing it is really not not a major issue. There's so much redundant blood supply, especially venous supply, that it ends up being just fine. So let me skip ahead a little bit here. Okay, so now I know it's a little bit dark here, but what you're seeing is this is the parathyroid gland sitting in the tracheoesophageal groove. And again, what we'll do is we'll dissect this parathyroid gland out, from the side, moving towards the middle, to the middle portion. Being careful to make sure that if the recurrent nerve is in that area, that we identify it and not use the cautery nearby. So here you can see the parathyroid gland. We're retracting this laterally, and there's the vascular pedicle. And so, we're just dissecting out the vascular pedicle here. And so once we divide the vascular pedicle, we'll ask the anesthesiologist to take their first pre-excision sample. So this is the T0 sample for the intraoperative PTH. And then let's skip ahead here. And so there it is, kind of just hanging on by the last thread. And again, even though we say there's a vascular pedicle, oftentimes there are multiple blood vessels that are supplying and draining these parathyroid glands. So you have to take multiple vessels in that area. And so that is essentially it. And then we'll close everything up and wait for the intraoperative PTH levels. So when you look at intraoperative PTH monitoring, most people will use the so-called Miami criterion, and the Miami criterion is that there's a greater than 50% drop in the intraoperative PTH at 10 minutes after the excision of the parathyroid gland, and that's a 50% drop from the higher of the pre-excision values, either the baseline or the T0, which is what we get right before we take the blood supply. Some people will say that the PTH levels should normalize as well in order to have as strict of criterion as possible, and a lot of the Italian groups use that criterion. But sometimes you start with parathyroid hormone levels that are in the 3000s, and there's no way you can get to normal from that standpoint. So you just have to kind of use a common sense approach to it. And typically we'll draw these samples from a large bore IV. You can do it from an arterial line or from the internal jugular vein, straight from the field if you like. The IJ sampling tends to be a little bit less accurate. I think I saw your next lecturer around, but if there are any other questions, I'd be happy to answer it. All right, guys, you're in the home stretch. Hang in there.